Hello, everybody. On this podcast, I'm going to talk about chapters 32 and 35, which is our last chapters of the semester. Chapter 32 looks a little bit more specifically at long term care and, really, in general, the types of care that can be provided for the elderly patient. And then chapter 35 looks at death and dying a little bit more specifically. We're going to start with chapter 32, on page 427. And if we follow our outline, number one, it says, how might the care needs of an older adult in assisted living, subacute care, and nursing home differ? What are the roles of you as a professional nurse in each of these settings? First, we're going to look at assisted living. An assisted living is a residential long-term care choice for many older adults now. And I really feel like these assisted living places have really come out in the last 10 to 20 years. They've really been popping up around our area. An assisted living, there's kind of two types. We refer to them as assisted livings, but usually, for the most part, a lot in these types of environments, they also might have an independent living area, an assisted living area, and then also some of them do have some dementia-specific care areas. Not all of them. All of them do, however. The real difference from assisted livings compared to maybe the nursing home that you did clinical in is these residents really are in an environment where they do not need 24-hour-a-day skilled nursing care, and they don't need constant monitoring at that skilled nursing facility. Assisted livings, if you've been in one, do provide some support services. They offer more of a home-like environment than a nursing home and are usually more or actually less expensive than the nursing homes. Just some interesting side notes about assisted livings to keep in the back of your mind. Most assisted livings do not have a registered nurse, coverage 24 hours a day. They might have a nurse there during the day that organizes pills or does some of the bookkeeping, those types of things. But they do not have coverage 24/7. They most likely will maybe have a nurse that's on call the rest of the day. Some state agencies may have professional nurses. Again, they might be on call or might monitor the facility in different ways to ensure safe and competent care for the residents. Nursing homes then are the second type of setting that we're going to look at. You guys all got to experience a nursing home in your fundamentals class. And really, nursing homes are designed for delivery of nursing care around the clock for those that need specialized care and really can't get it elsewhere. Nursing homes can be a complex setting depending on the type of a nursing home. They might include subacute rehabilitation facilities. They might also have hospice. They might have dementia-specific units. And most nursing homes, they might include up to 2 levels of care. Many of the ones, and if you got a chance to go to Sunrise, that's more of a chronic, long-term kind of custodial care. Other nursing homes might also have another level of care called skilled nursing. And skilled nursing is area of Medicare that they are on they end up being monitored more. Nurses have to chart on them more. They end up being followed up. But a lot of times they're in some type of a rehabilitation 90-day, 100-day program after they are discharged from a hospital setting. If you were over on Countryside, you may have seen a little bit more of those types of patients. Lastly, subacute care is a little bit more intensive than the traditional nursing home and more costly. Subacute care can be in a separate unit in an acute care facility. So you guys all experienced rehab this semester. Subacute is kind of one step lower and then nursing home care in regards to kind of what the patient is expected to do. Patients in subacute care have often been referred from an acute care facility, so like the acute care floor, maybe even rehab where maybe they aren't tolerating it as well. And so registered nurses are required to provide the management of these patients with complex health needs. Chronic long-term care is required, and they usually need 24-hour assistance. Again, that is done by a licensed nurse. Again, these subacute places can really be in an area of a nursing home, or they can actually even take place in a hospital. A lot of small town hospitals in Iowa will also be a provider for subacute care. Number 2, what are the goals of long-term care? Sometimes I think it's hard to see that in relation to what we kind of see in long-term care, but they do have some goals. If you look on page 430, box 32-3, goals for long-term care, really providing a safe and supportive environment for those that are chronically ill and functionally are dependent on somebody else to provide their care. They also work to restore and maintain the highest practical level of care, and so you might have seen in long-term care, we want to try to help them do as much as they can by themselves by preserving that individual autonomy. Trying to maximize quality of life, provide comfort and dignity at the end of life, really looking at coordinating a lot of interdisciplinary care. So there is a component of rehab in most facilities if they can get them back to home or a less restrictive level of care. Stabilizing or delaying progression of any chronic medical conditions, providing acute medical care, and creating more of a home-like environment, again, with the ability to provide those cares for the patient. So again, you can look at some of those on box 32-3 on page 430. Number 3, what quality measures are in place for evaluating nursing homes in the United States? What agency is in charge of skilled nursing facility regulations? If you turn to page 437, box 32-13 talks about the quality measures for nursing homes. Really was published by the Centers for Medicare and Medicaid Services, or CMS. And really what nursing homes are needing to report to Medicare and Medicaid to the federal and state levels is really looking at a couple of things they're really honing in on. They're really looking at the pain control of patients in the nursing home. Is it adequate? Is it covered? The second thing is new or worsened pressure ulcers. Again, we don't want new ones or them developing worse. Compliance with the influenza and pneumococcal vaccinations. We talked about in a previous chapter how the immunity system of an elderly person ages. And so with those, we can't keep up fighting those antigens. And so we really need to make sure that they're really doing influenza and pneumococcal vaccinations so that we can prevent the spread. When you have a large number of these elderly patients who have immune deficiencies and chronic diseases already, and then you introduce something or put them at a higher risk for influenza or pneumococcal, that can really, again, end up taking one or more people's lives in the nursing home. Pneumococcal is a vaccination for pneumonia, if you're not familiar with that, usually given to people with chronic health problems or people over the age of 65. Falls, they're also going to look at falls. How are they limiting or reducing the amount of falls in their facility? What kind of things do they have in place to stop that? They're looking at incontinence of the patient. Again, somewhat having to do with pressure ulcers and new formations of those types of things too when we look at the acid and bowel and urine and how that can affect the patient. Also looking at indwelling Foley catheters. They do not like catheters inserted and left into their bladder, so there will be a lot of documentation and noting. That's not just something that they want done anymore. I think back in the day, it used to anybody who was incontinent, there was thought of just using a Foley, but the risk of infection and those types of side effects, they don't want those Foleys just left in. And then lastly, restraint usage. A lot of nursing homes are actually restraint free. And I should denote that as a physical restraint free facility. Again, also, we talked about in the pharmacy, polypharmacy, or the pharmacy chapter with the meds, how a pharmacist will come around and regulate the amount of chemical restraints, antipsychotic meds that a person is on. So, really, it's very important when you look at this list of these quality measures that our role as nurses is to really follow through and make sure these are all taken care of. And if we do have something, a fall or some type of maybe restraint or chemical restraint usage, pain control, ulcers, that's documented appropriately for what needs to be documented. Number 4, visit the CMS website for data on nursing homes and compare your local nursing home within your zip code and look at their quality scores. So I do have some links. Sometimes they work better than others. And since we're not in class, it will be hard to do that. But I do really encourage you to look up your nursing home in your town or in your area and see how they rate, how their scores are. Interesting enough, you can visit any state and Google the nursing home and find out. Every year they have a site survey, a site inspection. I think some of you realize that you had to miss a day at both nursing homes this fall because of or had to come back here because of the state surveying being at the nursing homes. And that is public knowledge. So it should be displayed at the nursing home, and then also you can find those reports online. All right, switching over to chapter 35 on page 482. We're going to talk a little bit about grief and kind of types of grief and things like that to start out with. Number 5 talks about differentiating between grief and mourning. Grief, just a kind of a different process. Grief refers to the individual's response to the event of loss. So again, it's the individual's response to the event of losing something. Mourning represents the behaviors that a person who is bereaved or mourning uses to incorporate the loss experience into his or her life. Mourning sometimes is an active process, and behaviors that are associated with mourning are determined by social and cultural norms. So what might be normal or in one culture or ethnic group compared to another might be different. So again, grief is how the individual responds. Mourning is more of the behaviors that they use to kind of deal with that lost experience of and being more of an active process where they kind of work through. In number 6, it says identify and describe the different types of grief. And there's a couple that I want to hit on. The first one is anticipatory grief. It's really the response to a real or perceived loss before it occurs. So for an example, maybe you know somebody who is dying of some type of cancer, as an example. Anticipatory grief is how you respond or how you kind of respond knowing that that grief or is starting to occur, or knowing that that loss is coming. So it's anticipatory. You're anticipating it happening. The second one is acute grief. Again, acute is kind of it's happening right at the moment. Acute grief is really like a crisis. There might be physical and psychological symptoms of distress that might occur for various time periods, depending on the situation. Chronic grief then is again chronic. It takes much longer than expected. A lot of times, people who deal with chronic grief, they might have sadness that might linger or stay with them for a longer period of time. Some other signs and symptoms of chronic grief is they might stop the activities or kind of isolate themselves from activities or things that are going on that they may have normally participated in. Sometimes they might complain of intermittent pain of grief that might be triggered by anniversary dates or things like that, or different stimuli that are associated with the person that has been lost. So kind of when that chronic grief comes up, it might kind of increase at certain periods or exacerbate at certain periods of time throughout the year. Complicated grief then is a little bit more complicated. Grief extends beyond what we would call a normal bereaved adjustment period. They have a really hard time establishing, kind of getting back to normal, and it really just interferes with their kind of function or getting back to normal life after whatever grief occurred. The last one is disenfranchised or unspeakable grief. Really occurs when somebody really can't openly acknowledge or public mourn for somebody's loss. This might include a person who does not have a socially recognized name to be perceived or function as a bereaved person. There are some examples in the book. Maybe if you had a person maybe die in jail, it talks about maybe there was some types of issues where people weren't getting along. Maybe an ex-spouse where people, maybe that the divorce or something happened years ago, and they've kind of moved on separately with their lives. The divorced, one of the spouses dies, and it's kind of that disenfranchised, unspeakable grief that that person may still be feeling grief, even though they don't really want to say it or acknowledge it for the mere fact that they're feeling that way, just because that person, maybe was not a positive thing in their life, but they're still kind of going through and dealing with that form of grief. As you go down the outline there, you will see kind of a table that I put in there from Kubler and Ross. And Kubler and Ross talked about stages of the grief cycle, and I think this is really important. And when you see patients in the hospital or at different points in the clinic or wherever you're going to work, you might see them at different points of this stages of this grief cycle. So when grief occurs that might be acute, they might maybe shocking, they don't really know, or it's kind of unexpected, they'll first kind of hit this shock and denial. And the patient or the family members, it can affect both, might just avoid the issue. They might be confused. They might show a lot of fear. And just kind of be somewhat numb to what's really going on and to the reality. They also might blame others. One of the things that truly sticks out for me as a nurse dealing with some of the family members or patients is the blame. A lot of times patients would verbally or yell even at me or other nurses, get very angry. And really, it's really just a form of blame or denial because they don't know what else to do. It has to be somebody's fault, and you kind of end up being the person there that ends up taking kind of the the heaviness of their feelings. Then as that again kind of turns, it turns into anger. And so again, that's where some of that blame and that fear might turn into where their frustration, anxiety, they're irritated by every little thing you do. Again, they're going to start yelling and somewhat can almost be just very difficult to deal with because they're just so angry at the situation. Again, as that shock and denial again kind of turn into angry, a lot of times the nurses are somewhat end up being some of the brunt of that shock. But then again, as it turns into that anger, we sometimes get to be the person on the receiving end because again, they're just in that stage of the grief cycle. After that, then it goes to depression and detachment. They feel very overwhelmed by the new change. Again, this might depend on what the change is. They have a lack of energy. They feel very helpless. They just don't know what to do. As we move kind of back up, then it says dialogue and bargaining. They might start to reach out to others. They might desire to share their story. They might struggle to really understand why. Why did it happen to me? Why did it happen to them? Things like that. And so they're really trying to kind of go through that psychological process of those whys. After we kind of move back up, then we get to the point of that acceptance. We have a new plan. We kind of start to move forward with life. And then again, returning back to that normal functioning or that meaning of life where they feel secure, they have self-esteem, they feel like they have meaning in life, and they feel empowered to make a difference. So you can kind of see, maybe you know of people in a grief cycle who have hit some of those stages. And it really is, Kubler-Ross, it's a well-known cycle to become familiar with and stage. And you will definitely see this in the different types and kind of where you hit those patients in their care. Number 7, it says, describe the person who is most likely to effectively cope with loss. Describe who is least likely to effectively cope with loss. So everybody deals with loss and grief on some extent. I always like to say grief and loss don't necessarily have to be with dying specifically. You can grieve over a lot of things in life or have grief or feel loss. Again, it's not just a person in this chapter. We're kind of focusing on loss, death, and grief. But grief can really kind of apply to a lot of situations in life. Individuals and families most able to deal with loss and cope with loss are people who confront the reality and make appropriate action and just work towards the solution. They consider things, alternative things that might be beneficial. A lot of times they are the people who have good communication. They seek and use people or resources that can constructively help them. They also need to be willing to accept the support when offered. Sometimes that's a difficult thing for people, and can keep up their, just a positive thought or a high morale. Individuals and families who are least likely to effectively cope tend to be more rigid, very pessimistic, demanding, and experience kind of very emotional extremes. They're kind of all over the board. They expect perfection from themselves and others. A lot of times these patients tend to live alone. They socialize very little and have few close friends or an ineffective support network. If they already have a history of mental illness, have a lot of guilt or anger, again, it might make it more difficult for them to effectively cope with a loss. Number 8, it says describe nursing interventions to assist with individuals experiencing loss. Really, we're trying to promote health at the time of a loss, and so really including actions that can empower a family to cope with death in a manner consistent with maybe their traditions. If you look on page or on box 35-15, again, quite a few pages into the chapter here. (35-15) on page 498. Nursing skills needed for the practice of palliative care and end-of-life care. Really looking at the ability to talk to patients and families about dying. I think that's one of the hardest things to do as a nurse, is to really look at and talk to people in that process, knowing that that's most likely going to come. Being knowledgeable about symptoms, the control of symptoms, and how to have those pain controlling techniques. The ability to provide comfort in orientated nursing interventions. Again, I think it's being comfortable with talking and supporting the clients that are dealing with death coming. Recognize physical changes that are imminent with death, and we'll talk about those in a little bit. Dealing with your own feelings, sometimes taking care of people who are dying, especially people who work like in hospice and those types of things, can be very difficult for your own psychosocial when you're constantly dealing with people in that stage of life. Dealing with angry patients and families, again, depending on what cycle, if something, if death came instantaneously, that anger or that blame, that denial can be very difficult to deal with in that regard. Be knowledgeable and deal with the ethical issues in administering end-of-life and palliative care therapies, and we'll talk a little bit about that here. And we've talked about that with some of the, I gave an example of my grandpa and the feeding tube just the other day when we talked about durable power of attorney and living wills. Be knowledgeable of the legal issues of administering end-of-life and palliative care. Again, being aware of what you're doing and how that affects the patient depending on certain circumstances. Be adaptable and sensitive to religious and cultural perspectives. Again, people from all different backgrounds might do different things as a person dies. They might have different ceremonies. They might have different rituals or cleansings or things like that. So be willing and try to adapt and be open to some of those cares. Number 9, differentiate between palliative care and hospice care. Palliative care, I think, again, we've talked about this a little bit last semester, but palliative care is really appropriate at any time to help reduce the suffering of a patient. And so palliative care is not necessarily for people who are actively in the process of dying. It's appropriate for patients who may be receiving curative treatment, but also are needing somebody to kind of work with how to deal with the pain and just kind of providing a sense of comfort and trying to figure out different ways to make them comfortable. It also can be, again, used for patients for whom curative treatment is no longer effective. But that's the curative treatments, the use of that in palliative care is different from where it can really differentiate from hospice. Palliative care may also be provided when a client decides to continue treatments of existing conditions but refuses aggressive treatment of any new health problems. So maybe they continue to kind of go with the course of action that they have gone with, even though they're not going to start any new treatments or issues. Hospice then really differentiates because we're looking comprehensively in different disciplines, really, of care to people with a prognosis of 6 months or less. Hospice services, again, looking at that interdisciplinary comprehensive care, can include the medical team, so the doctor, nursing assistants, chaplains, social workers, volunteers. There are a lot of volunteers that support hospice and do different things, from going around and giving massages to playing guitar and singing. There's many things that people do. Hospice provides care not only to clients, but also really is a supportive service for families and friends. They offer support groups, bereavement services, and those types of things to help kind of that transition during that tough event of that family and friends' life. Palliative care may lead to hospice care when treatment is no longer effective and the client has limited prognosis. So even though they do overlap, there are kind of separate differences from them. So just as a clarification, with hospice, we talked about the prognosis of 6 or months less. And then they also, then again, differentiating from palliative care is that the treatments are stopped. And really the focus of hospice is really looking at making sure that they have quality, that they in their life in comfort and as close to pain-free as they can get them. So again, they're looking at quality versus quantity. But they on hospice they do not treat what the active disease or whatever that thing is. And then lastly, number 10, identify signs and symptoms associated with the terminal phase of living and dying. So as a patient, if you look on page 498, table 35-1 really talks about best nursing practices of signs and symptoms of when a person is approaching death. When you look at a physical body of somebody approaching death, some of the things that you'll notice. So coolness is the first one. Coolness might be associated, especially you're going to see the coolness happen first on the extremities. So their feet or their hands might become cool to touch. And you can kind of read the rationale on page 498 as I go along in some of the interventions. Really looking because of their blood flow is decreasing. And so that coolness, that blood flow is not getting to those extremities. They're going to sleep more. It takes their body a lot more work to continue. And so, again, they will be sleeping a lot more times. Disorientation, because of some of the metabolic changes, electrolytes, things like that are starting to go out of balance. They might become somewhat disorientated. And so we might see that start to occur. Fecal and or urinary incontinence, as things slow down, the muscles will start to relax and they won't work as well. So increased muscle relaxation, again, keeping that patient clean when we change them or turn them every couple hours, again, making sure that we're looking at that and monitoring that. Noisy respirations, because they have poor circulation of their blood and those types of things in their body. Again, with the lungs and everything, everything's slowing down, and so we aren't getting that circulation. And so a lot of times in the lungs, they'll start to fill up with fluids, and we'll hear some of those noisy respirations. If you can elevate their head or the head on a pillow or the head of the bed, gently turn them from side to side to kind of facilitate drainage is some of the important things that you can do. They might become restless. Metabolic changes, they're not getting as much oxygen, can make them restless. So kind of turn down the lights, back rubs, arm strokes, soothing music, Those types of things can help. There's also medication, of course, that can also help with that, to kind of reduce that. Decrease their intake of food and fluids. Again, they don't have as much ability. They lose that ability to be able to use those muscles. Um, they're trying to just conserve energy for basic function. And so a lot of times we'll continue to kind of go down to where they just stopped eating or they stopped drinking. Never force feed or never force somebody to drink in an actively dying process if they're not coherent. You can't just stuff food and stuff drink down their throat. Decreased urine output as their fluid intakes, again, their poor circulation, it's going to be decreased circulation to the kidney, so urine output is going to decrease. And then altered breathing pattern, again, because of the metabolic and oxygen changes, you're going to hear different patterns and they're going to start breathing harder and faster a lot of times towards the end. Again, elevating the head of the bed, oxygen, or different things that you can do with that. Emotional or spiritual, they might start to withdraw. Some people do talk about vision like experiences. They might, again, become restless, might have communication issues as they're kind of working towards that. A couple of things to keep in mind that I always like to share. Hearing is the last thing to go. There has been studies and things that a person hears, kind of the last sense is the hearing. So making sure that when you're taking care of this patient in their room, that you don't talk about the patient, in regards to when you're caring for them, because they most likely can hear what you're saying. And again, that's kind of the last thing to go. As they are in that actively dying process, you might see rigor mortis set in. You'll see where the extremities, it kind of starts in the extremities, they'll start to get pale. They might kind of get like an ashen gray color. And then you'll kind of see what we call mottling, is where you push down on their skin gently, like you're checking a pulse, and it will just stay white. It really won't have any type of blood flow or anything to that. Again, it's hard to differentiate. Breathing can be very different from person to person. I've watched people die that are very relaxed in their breathing, and I've also watched it where people are like gasping for air towards the end. And so that can be very difficult for family members to watch. And I think we'll end there. If you have any questions, please let me know. Thank you.